and we went to the ACNP in Phoenix, and then we saw a talk from Alex, and we were very impressed. And I remember that we talked. We need to bring him to Green Rounds in Maryland. So we really appreciate that you came from far away from Calgary. I know that you had to change flights and you had a lot of problems in the trip here to Baltimore. So we really appreciate that you are here. So a little bit of the background from Alex McGeer. So he did his college in McGill University in Montreal, and then he did his medical school in Toronto. But always he was able to combine a clinical training with preclinical training. So when he went to the residency, he went to the University of British Columbia in Vancouver. He was in the research track, and at the same time, he did his PhD. And his current lab combines both preclinical and clinical studies. So it's mostly focused on mood disorders with preclinical models, trying to understand better the neurobiology, the neural circuits, and while the work focus on humans, trying to come with the new treatments, mostly non-invasive treatments. So thank you so much for being here.
All right. Hello, everyone. Thank you, Gustavo, for having me. I'm thrilled to be here. I don't get to come down here often enough. This is my first time in Baltimore, so I'm very excited to be able to tour the city. Not as much as I'd like because my flights were delayed, as said, but I'm very much looking forward to sharing our data with you. I'm going to be sharing a story we've been developing over the last couple of years in my lab. I'm still relatively new. I started in Calgary in 2018, and then things got bogged down from this small little infection we all had to contend with. But things are kind of picking up again, and I'm able to kind of expand on some of the data that Gustavo and Todd saw at ACNP a couple of years ago. So most of what I'll be presenting today is unpublished, and I'm really keen to hear your feedback. And I'm also very open to being interrupted. So don't necessarily wait until the end if you have a question. I'm happy to answer as we go along. I do have to disclose that I have a conflict of interest. As we were just talking about, a lot of in the meetings we're having prior to this, a lot of the data I'll be presenting is using a particular small molecule that is now no longer available. And so we have a commercial entity that we've established to try and make that molecule available once again. And so I have a clear conflict of interest, and you should bear that in mind because it will make me no money at some point. I have a couple of learning objectives or things that I'd like for you to walk away from today's talk with. Effectively, I'd like you to be able to understand what our presumed mechanism of action for transcranial magnetic stimulation is, and that is one of our most established non-invasive brain stimulation treatments for depression and other mental illnesses. And I say presumed because it is all conjecture. It's all been hand-waving, and we're really only now starting to kind of probe the underlying mechanisms for how this works. The clinical efficacy of these treatments and where our gaps are and how we're trying to fill those gaps with some of the strategies that we're employing. And I'm going to dedicate more than half the talk to understanding the caveats and pitfalls of the work that we're doing and how our initial successes made me very nervous, and that has motivated a lot of the work that I'm going to be presenting. This audience needs no education on this, but major depression is extremely common. We're talking about 10% of Canadians and just as many Americans. The annual prevalence is around 4%. It's a little bit higher in the US, but that means millions and millions of people. So I didn't edit this because I normally speak to Canadians, but that's 1.5 million Canadians, and it's 30 times as many Americans. So that's a lot of people. In Canada and in most of the developed world, it accounts for more disability than all of neoplasms and much of infectious disease. It's only surpassed by infectious disease globally. So this is one of these diseases that we don't treat particularly well, and it's very common. And in my tiny little neck of the woods, this is a staggering cost, partly because it's a publicly funded healthcare system. But you can imagine that in systems where people were even not as well treated or don't have access to as much care, this would be even higher because the indirect costs would be absolutely staggering. These are our national guidelines, which are only marginally different than your national guidelines. And what I've done is I've stepped everything according to how we would progress through the different phases of treatment. So effectively, step one are medications, psychotherapy, non-invasive treatments like bright light therapy, stuff like that. Then you go on to medication combinations. You consider bringing in TMS at that point. And then you get into medication combinations and experimental treatments that are less and less effective and more invasive. The exception being, of course, ECT, but ECT has its own problems and people are not really eager to get that. But I think what you'll see in this graph here is that I've plotted the response rate on the x-axis and the different levels of invasiveness as you go down on the y-axis. And that top right quadrant, that's empty. We really don't have anything in that top right quadrant. And I apologize, this slide's a little bit old. S-ketamine is in the step 3, and it's around 47%, if you remember the JAMA Psychiatry papers. So really hasn't changed this picture with the addition of these new treatments. And my conjecture is that if we were to start to go back and start to think about the mechanistic processes underlying some of our treatments, we can start to populate this top right quadrant with some of our existing treatments if we were to think about how they actually function and make them work better. A few words on TMS, because that'll be central to today's talk. It's high school physics. It's really easy to understand. You're using electromagnetic induction of a current in the brain. You can do it non-invasively outside the head. That's a really dumbed down version of the physics. It is actually rather sophisticated, but it doesn't need to be for the purposes of this presentation. And you can achieve all kinds of different electrical fields by having coils of different orientations and designs. And so the most common one is all the way to the right. So these are all Brainsway. Brainsway doesn't pay me. I'm just putting them as examples for how radically different the coil engineering can be to achieve different fields. And all the way on the right, you have the most established and the most conventional one, which is a figure of 8 coil, which has these two little donuts and intersects two magnetic fields. And at their intersection, you have enough current to actually elicit, a magnetic field to elicit a current in the brain non-invasively outside the skull. And here's the presumed mechanism of action. And I'm highlighting presumed. Is that by delivering patterns of these pulses to the brain, we're actually driving adaptation in the brain through processes of the synaptic plasticity. And this is an offensively dumbed down version of it, but you can see how by delivering different protocols, one might induce long-term potentiation or long-term depression, whereby either the synaptic connectivity is increased or synaptic transmission or efficacy of synaptic transmission is increased or decreased accordingly. So again, it's our most established evidence base, with the exception of ECT, for non-invasive neurostimulation. It has an FDA indication, but so does OCD, nicotine abstinence, and migraine headache. So this is a versatile tool. This is not a depression treatment. This is a brain stimulation tool that we can use in a variety of different contexts and to do a variety of different things under different settings. But effectively, this conjecture is that it does depend on synaptic plasticity at the cortical target and the subcortical projections of that target. So this really is a circuit-based intervention, and we kind of hand wave and pretend we understand that, but we have to go back to basics every once in a while and remind ourselves of that so that we can make the treatment work better. Because despite 25 years of research in TMS and all kinds of different permutations of the protocols, whether it be high frequency, low frequency, unilateral, bilateral, all of these different permutations, there's equipoise across all the protocols. And those in the know may know that's not entirely true anymore, and I'll come back to that later. But effectively, all of the conventional protocols do not crack that 50% response rate. There seems to be some kind of a ceiling that is either because of patient selection, the actual underlying biology, or the circuit being targeted. Oops. And so there's very smart people, much smarter than I am, who are trying to come up with different protocols, different customized targeting by doing precision medicine, trying to get at the exact circuit using, seed-based fMRI to get from the anterior cingulate to the precise place within the dorsolateral prefrontal cortex that we should be targeting. And so far, there have been gains, but they've all been really marginal. We're talking about changes from 50% to 58 to 62. These are small marginal improvements that are really important, because if you're that 10% that got better that wouldn't have otherwise, that means something. But Again, going back to basics, my conjecture is I don't think TMS is the problem. I think TMS is doing exactly what TMS is supposed to be doing. We're just asking something of the brain, particularly in the case of depression, that it can't readily do. Because we have an abundance of data over the last 40 to 50 years to say that individuals with depression have cognitive impairments, which is a proxy for synaptic plasticity. We know the postmortem data showing that they have phosphorylated CREB differences. We have all kinds of mRNA studies from the early 2000s and a lot of other newer studies showing that there are deficits in synaptic plasticity in the disease. So you are effectively asking the brain to adapt in a way it can't do to the stimulation protocols you're delivering. And in the last 10 to 15 years, we've been able to probe that directly with TMS, the tool that we're using to treat people, right? So you can actually go and use TMS to probe whether or not the brain can adapt to the protocols that you're delivering. So here's an example using something called paired associative stimulation. For those that are interested, it's a means of using median nerve stimulation in conjunction with TMS so that the waves collide at the same time, and you get a paired associative strengthening of that plasticity. And so what you can see is that in the solid lines or solid dots, healthy controls show a strengthening of the plasticity or of the motor evoked potential, which is a proxy, and I'll get to that in a minute, with this protocol, whereas individuals with depression don't. Here it is replicated again. We have deficits in individuals with depression. And perhaps most importantly, there's this newer protocol called intermittent theta burst stimulation, which has gained FDA approval for the treatment of depression because it is non-inferior to the very old protocols that take 15 times as long. And you'll see individuals with depression who are on the bottom and do not potentiate, do not or show evidence of impaired plasticity to the very protocols that we're using to treat them, right? And this is Stéphane Vigneault's work that I'm highlighting, but also in the reference below is work from our lab showing the same thing. So my point is, I think we have neglected the fact that although we have this great tool that can do wonderful things, we've been studying it under the wrong circumstances and with the wrong assumptions, because we believe that the depressed brain can do what a healthy brain can't, and it simply can't. So the first thing we did was we went about trying to rescue synaptic plasticity in depression to see whether or not, from a physiological standpoint, we could justify using this clinically. And so very briefly, my fantasy for the last 15 or so years, which I couldn't pursue because I didn't have my own lab and nobody would support me to do it, but is this adjuvant space. We know a lot about LTP and LTD from the preclinical world and from ex vivo slices. And we know that we can use various adjuvants and drugs to bring things in with stimulation protocols to enhance or block synaptic plasticity. And this is a systematic review that we just published of the entire literature in human TMS plasticity using adjuvants to either increase or decrease measures of LTP-like or LTD-like plasticity. And what I'll highlight here is we know a lot. We actually do know a lot. There's been a lot of good work done. But they're all small studies. There are few numbers of studies per agent. This is an area that is becoming active once again. It was active about 15 years ago, and it's now coming back. And so I think we're going to see an explosion in this space. But what I'll highlight is that the two areas that we know the most are about the NMDA receptor and about dopamine receptors. And so we know that antipsychotics in particular block the effects of TMS, whereas drugs that we can't necessarily give because they have a lot of abuse potential can enhance it. Whereas if you go to the NMDA side, we know that if we have NMDA receptor antagonists like dextromethorphan or memantine, we can block the effects. But there's this one little molecule that's very interesting called D-cycloserine, which we can invoke to try and enhance the effects. And so that's where we started. Yes. So we do think about that. There just have been, oh, sorry, I'll repeat the question. Or Todd, please.
Question. So going back to this slide, I noticed there aren't any indicators of drug approaches to target the AMPA receptor in first.
So the easy out to that answer is that they simply haven't done the studies or they haven't considered the drugs for their off-target effects at the AMPA receptor as a potential explanation for the effects. But again, this entire field went dormant from about 2015 on. And so it's only now starting to ramp up again. And I think we are going to start seeing that. But it's a cop-out, but.
Yeah, I appreciate it. We're doing a Carlos Serrati in IMH with perampanel.
Oh.
And ketamine asked the question whether you block AMPA receptors in people with ketamine, whether you block both induction as well as maintenance of antidepressant.
Very cool. I will give the caveat here that this is a review limited to past protocols, high frequency stimulation protocols, intermittent theta burst protocols. It doesn't look at any of the other things that could be studied. It's really just trying to look at when TMS has been used to induce plasticity, what drugs have been combined. But yeah, there's a huge intersectional space there for us to explore. A few words on this molecule, because it is an interesting molecule. One of its mechanisms is as an NMDA receptor partial agonist. And as you know, partial agonists are really complicated molecules. They do different things at low and high dose. So at low dose, this has been shown to agonize the receptor and facilitate NMDA receptor signaling. Whereas at high dose, it's an antagonist. It can actually have profound psychotomimetic effects, just like ketamine. One of the nice things is that it crosses the blood-brain barrier, and there aren't that many well-tolerated NMDA receptor agonists that do that. But more importantly, for my purposes, because I didn't want to spend 20 years in development, it is FDA approved as an antibiotic at very high dose for the treatment of multi-drug-resistant tuberculosis and at one time urinary tract infections. But what that means, that means that I can leapfrog all of the safety and go straight to human testing. So that really cuts 20 years off the development process and allowed us to really go straight into testing the things that we want to test in humans. So very briefly, and I will come back to this later in the talk, but when we are trying to model plasticity in the human brain, one of the easiest ways to do it, because most of the brain doesn't have an immediate output, is to target the motor cortex. So you can deliver pulses to the motor cortex to define motor representations and measure the motor evoked response with EMG on the skin, non-invasively. So yes, it is a couple of synapses removed. It's not a very clean measure. You have to get a lot of averages to get a true signal, but you can deliver these pulses and get what's called a motor evoked potential that you can measure on your defined muscle of interest. We use the first dorsal interosseous because it's really nicely defined and it's easy to find on the hand knob in the motor cortex. But there are a couple of different things you can do to study plasticity. You can do time courses. There's serial measurements, which measure something called I waves. Don't worry about it. Or you can do input-output curves, kind of like you would in electrophysiology and ex vivo electrophysiology, to look at outputs to a range of intensities. So you can really look at the curve, which usually has a sigmoidal function, and you can see where you're getting saturation and maximal excitation of your TMS space, because it's effectively just exciting a larger and larger volume as you're going up. And so our first foray into this went terribly. Probably I now know because my methods weren't as good as they need to be. But in healthy individuals, when we did this, it blunted plasticity, which, while interesting, you can get a paper out of it, and that's great, is not really what we were trying to do. And it did force us to take a step back and think, what is it we are trying to do? And then I came to the realization, well, I'm really not trying to enhance plasticity in healthy individuals. I want to try and rescue it in depressed individuals. So we repeated the experiment with slightly better methods, and we could show that we could actually not only demonstrate the deficit in individuals with depression, we could rescue it as compared to placebo by pairing it with D-cycloserine at a low dose. So we have enough data to say that we can go on to some kind of clinical intervention to try and enhance outcomes. And so that's what we did. So I'm going quickly through this because this is all published data and I don't want to bore you. I want to leave the good stuff for the end. But the clinical trial design was all pre-registered, best standard practices. It was run through probably the darkest part of that pandemic that we had to deal with. And so the people that we had coming were quite sick. They were motivated. They came every day because they were quite sick and they weren't getting access to ECT at that point any longer because our ECT service was sucked because of aerosolized risk. And so these people were motivated. It was a single site at my institution, so the University of Calgary, 4 weeks, double-blind, placebo-controlled. And we used a variation on the FDA approval, which is the 600 pulse intermittent theta burst stimulation protocol. But as we were just sharing with the TMS group here, the FDA approval is at 120% of motor threshold, which is bloody uncomfortable. And I don't want to do that to people. Plus all the physiological data is done at 80. So we did a variation on the approval and did it at 80%. So that's important to highlight. And the other thing is that we didn't want this to be just an academic finding. We wanted this to be something that could be rolled out. So we used a targeting method based on surface anatomy. So, early 2000s kind of approach, not trying to use fMRI to get really customized targets, really maximal rollout ability. This could be implemented in existing infrastructure with no problem if it worked. What I'm going to highlight here, don't worry about the text and all that, is based on our healthy data where we blunted plasticity, we knew there was a risk this could go the wrong way. We knew going into it that there really was a chance that this could make people worse and block their therapeutic effects. So, and that with the combination of the fact that this is an antibiotic and you probably want to do subchronic administrations of an antibiotic over time, we limited it to the 2-week urinary tract infection indication for cycloserine. And so they only got the drug for the first 2 weeks so that in the second 2 weeks, if there was occlusion, we could actually disentangle that and see them improve again or the converse. Again, busy, but typical clinical trial. To get 50 randomized, we had to screen 5 to 1, which is very typical for this kind of study. We had really good recruitment with the exception of a couple of people we lost to either a COVID infection and they couldn't come any longer, or when our institution shut down because of that fateful day, March 12th. I still remember it. But we lost a couple of people there. But otherwise, our retention rates were very high. This is just to give you an idea of our sample. So again, quite sick. Average MADRS scores in the low 30s. Most had, or many had attempted suicide in the past. They had multiple different trials of antidepressants in the current episode. So pretty sick sample. And I'll present the primary outcome, which was the MADRS score. And so here you see a very robust separation between the combination group and the placebo plus stim group. And that's already evident at 2 weeks and just becomes more marked by 4 weeks. So that corresponds to a mean difference of 6 on the MADRS. And although it's contentious, most people would agree that the minimally clinically important difference on this scale is 3. So this is not only statistically significant, this is clinically significant. That is a very appreciable effect. And for those of you that think in effect sizes like I do, an effect size of 1 is a very large effect. That's stimulant versus placebo for ADHD. This is not a small effect. So definitely something we want to make sure is real, because if it is real, this could have a real effect on people's lives. It was also reflected in response rates, so separating by 2 weeks and then further by 4 weeks. And you can see that 74% response rate, far exceeding the 50 that we would expect in a typical population. Sometimes people give me guff about the fact that our placebo group are down around 35. But if you look at all of the data, remember, this was a 4-week study, not a 6-week study. All of the 6-week studies show about 35% at 4 weeks, and then they get to 50 by 6 weeks. We wanted to minimize the floor effect, and so this was just a 4-week study. So this is exactly what you'd expect for the placebo group, and also present in the remission rates. So pretty exciting data. I think it's pretty cool. I don't know about you guys, but the problem is I'm telling you that there's a synergistic effect going on, and this design can't actually tell you that because it could be additive, it could be any number of different things, except that we had this kind of built-in sanity check for a synergistic effect in the study, because cycloserine is very slowly absorbed. You need to take it about an hour to 2 before your treatment, otherwise there is no cycloserine in blood, or in brain rather, I should say. And as you might expect from a severely depressed sample, less than half of the doses were taken within an hour an hour to 2 before treatment. So this gives us a way to see, well, is it just the adherent patients? Is it the good patients that are getting better? Or do you actually have to have cycloserine in brain? And so you can separate out those who responded versus those who didn't for your 2 groups, and look at a cumulative distribution plot of when they actually took their doses. And you can see it isn't just the good patients that are getting better, because when it was placebo, those lines are overlapping. It didn't matter when they took their pills. They were getting predictably better between the two conditions. Whereas in the combination group, if they took it as indicated, so an hour before the treatment, they had a much better likelihood of responding. So we have some kind of internal sanity check to say that this is in fact a synergistic effect. I'll pause there just before I keep going. Any questions before I start going into the unpublished stuff?
I'm curious, what are the side effects of D-cycloserine? And extension to that is, do subjects know whether they're getting D-cycloserine versus placebo?
Sorry, I realized that was too low the whole time now. No, at this dose, there are no side effects. I've taken it many times recreationally. No, but I'm always our first test participant for everything. It has no side effects. Blinding is preserved. People assume they're on the placebo condition because they do not have side effects. So it is really nice in that way. There is no unblinding. And you'll see in a few moments, we did do a study where there was a 2-to-1 randomization. So they were twice as likely to have drug than placebo. And I'll get to that in just a sec. And 20% of the sample thought they got drug, whereas 60% got the drug. So it is kind of interesting that way. So some kind of interesting things that we also included as secondary outcomes for this study that were kind of pie in the sky, but may have worked out. So we found evidence for functional remodeling. So we included cognitive testing, and I'll readily acknowledge this is not the best battery to do this with. This is the ThinkIt that was developed by Lundbeck, but it's freely available, and it is you can actually go through the back end and get access to the data and not just the gamified scores that it spits out. So it is very useful in that way, because this was funded on a NARSAD Young Investigator Award, so 75 grand. So I had to find any cost savings that I could anywhere. And what it is, it's a gamified version of established cognitive tests, with subjective cognitive function being the perceived deficits, a choice reaction time, a one-back task for working memory and attention, digit substitution, and a trail making test for executive function. And what was very interesting is that this task, admittedly not exclusively a working memory task, and I acknowledge that, but it is still a working memory task, which is highly dependent on the target, right? So it's highly dependent on the dorsolateral prefrontal cortex. So that was where we really wanted to see if there would be an effect and if it was specific to that, independent of the other areas. And so we saw very marked improvements in subjective deficits, which you might expect because they're getting better and they're getting more better. And it is accounted for by the gestalt of their depressive symptoms. So if you control for how much better they're getting in depression, this is no longer an effect. It's accounted for by how much better they're doing overall. But that one-back task, that had a specific effect that was independent of their improvements in depression. So suggesting that there may have been some kind of functional remodeling or some kind of functional change specific to the cognitive tests that depend highly on the target site, which is very interesting. What Gustavo didn't say is that the first 10 to 15 years of my academic career were actually doing suicide research. So suicide is near and dear to my heart, and I'm passionate about it. And so we looked at suicide specifically, and you're all clever people. You know, 2 on the MADRS is not actually suicidal ideation because we couldn't have acutely suicidal people in the study. But I do want to highlight just how robust that effect is and how you have a disappearance of suicidal thoughts, which is quite remarkable. And then what we embedded in the study is something called a death-suicide implicit association test. So you'll probably be more familiar from implicit association as the test that can tell you if you're racist or not, or you're sexist or not, from the early 2000s from Greenborough. But you can leverage implicit strength and reaction time differences. So pairing suicide with me or not me death, that'll give you a reaction time difference, which might have something to do with suicide risk. And you see a robust decrease here. Now, I know this sounds airy-fairy, and I can see Todd's face, but this predicts suicide attempts within 6 months. So this is the meta-analysis we did of all the studies that have been done. And this cognitive test, performance on this test, is associated with 3-fold increased risk of suicide attempt within 6 months, suggesting that not only are people getting better, you might actually be impacting their long-term trajectories. Okay, so what have I told you? I've told you that TMS has a presumed mechanism that is driving synaptic plasticity. Our data using low-dose D-cycloserine on both outcomes.
Where are you?
I think that there is someone online.
Oh, okay.
Yeah.
We can recover plasticity. We can show better cognitive outcomes. We can improve cognitive function. And there's this interesting phenomenon with implicit association with death, which might be used to change suicide risk, maybe. All right, so I sat on that data for quite a while because we had to get IP on it. And as I was sitting on it, I realized I was an anxious individual. And so I started worrying about all the ways this could go wrong. And I want to share some of the things that I was worried about at that time and what we've been working on to try and mitigate that. So the problem is synaptic dysfunction is a catch-all term for a lot of different things, and it's common to a lot of different neuropsychiatric diseases. So is this a strategy that can be used transdiagnostically, or is this a depression-specific thing? Because as I told you at the outset, there's indications for OCD, for nicotine abstinence, and for migraine headache as well. So I know, because I know psychiatrists, once it was published, people are going to start handing it out for different indications just because they want to give people the best chance to benefit. And it was important to me to know that it would actually work, because there's always the risk of, if you're blocking endogenous glutamatergic signaling, that you could really blunt the effects of TMS. The second piece is we limited it to 2 weeks for neurotic reasons. And so the question is, can we combine it with typical courses of TMS? Can we do longer than 2 weeks? Is that safe, both from a cycloserine perspective, but also from a combination perspective? The third piece is this acceleration or enhancement? Because if it's just acceleration, you're getting there faster, might not be that useful. This might be a lot of work for something that you could just do by doing more treatments in a day, like the same protocol or something like that. But if it's enhancement, then this is really useful and we should be pursuing it. And the last piece is, again, the same protocol that I alluded to earlier has really upended this field, where they're delivering 10 treatments a day on the hour, every hour for a week, and have shown really robust effects. But they're pairing it with this customized precision targeting. So the question is it going to be safe with daily interventions? And within 2 weeks of the paper being published, I had people in San Francisco doing it in combination with Saint. So I knew that was going to happen, and I knew this was something I had to try and get ahead of to see whether or not this was going to be potentially harmful. So the first thing we did was we went to the next most used indication for TMS, which is obsessive compulsive disorder. And this study was just finished in December. It was finished in December because the North American source for D-cycloserine, which was manufactured by Parcelex and Purdue, dried up. They ceased distribution, so you couldn't get access to it anywhere in the country. So when our drug lot expired, the study expired. Study terminated prematurely, unfortunately. But here we had a 1:1 to 2:2 randomization of sham with either placebo or D-cycloserine, and then intermittent theta burst stimulation with a placebo, or intermittent theta burst stimulation with D-cycloserine. And I mean, admittedly, a small n. This is, again, a very, very robust effect. And what I'll say is that I suspect this is too good to be true, and that the numbers you'll get regression to the mean at some point. But I do want to highlight that this blue line, which is the effect of stimulation on its own, does match the approval trial. So a drop of about 3 to 4 points on the Y box is what got TMS approval for OCD. So our data is on par with what you'd expect in this population, and it's really a very robust effect in the combination group. And just for context, you don't see this in deep brain stimulation. You don't see this in capsulotomies and cingulotomies for the kind of population we were dealing with. So it is exciting, at the very least, to spur interest to take this further. Yeah, Brian. No, I was glossing over that. So this is using all of the parameters that are approved for the OCD protocol. So it's a 4 centimeters anterior to gastrus soleus hotspot. So it's targeting the midline PFC with a very diffuse coil that's meant to go deep and ostensibly target the anterior cingulate. Yeah. And again, this was also reflected in the CGI. So a global assessment of their function is also picking up this, which is usually quite hard to meet. Okay, so maybe too small a sample, data is a little too good to be true, but it's entirely possible this could be used across diagnoses. So what about 2 weeks? Can we push past 2 weeks? The first thing we did was we wanted to answer the two major safety questions, which are really, is it wise to administer a subchronic intermittent antimicrobial, or are you going to get C. diff infections or some other problem? Are we going to run into problems by doing this? Are we going to do harm? Because that's the worst thing that's what we would want to avoid at all cost. The second piece is that I've alluded to this fact a couple of times, where this drug does different things at different doses, but doses just are effectively a proxy for the serum concentration. So what about, so this is the weight distribution for everyone who participated in our study. The dosing of 100 milligrams that we use is based on data from 70 kilogram males. What if you happen to not be a 70 kilogram male, or what if you happen to be a 70 kilogram female? Do we have to think about this differently? So one of the things we wanted to see was whether we needed to think about a weight-based dosing, and whether we wanted to make sure that we weren't getting day-on-day accumulation. So that by 6 weeks, if there is, maybe you're going into the antagonist range and you are doing harm. So this is the safety, like the big safety question that we were trying to get at with this study. And what we did was we did a pharmacokinetic study. So this is just with 12 individuals with moderate to severe depression. What we did was we first gave them a single administration of the one-size-fits-all dose, so that 100 milligram dose, and we did a PK curve. So sampling every 30 minutes out to 2 hours, and then at 24 hours to determine clearance. Then we took the weight-based dose, and we started to deliver treatment with it, because it's very hard to convince people to give 16 vials of blood without them having some benefit from it. So we gave them a treatment in combination with it. It's not unethical to do that. That was the ethical thing to do. I wasn't incentivizing people to give me blood just by tricking them into getting better. But we did it at day 1, day 5. So this is usually Monday to Friday. So day 5 is the last day of the week, and then they come back the following Monday. And day 6 is that Monday where you can see whether or not have they fully excreted all the cycloserine over the weekend. And then we gave them a full 4-week course of TMS in order to see whether or not it was safe to have the combination of stim and drug. All just negative stuff to show you it's safe. Nothing changes. They drops their sodium ever so slightly, slight drop in hemoglobin. None of this survives correction for multiple comparison. So on lab tests, everything seems fine. We're not worried. I literally got this data on Friday. So this is really new to me. We sent this all out for assay to the National Jewish in Denver, and it literally just came back. So here you can see the curves for individuals with a fixed 100 milligram dose, and I've color-coded their weight band in which they are. And so you can see quite a lot of variability, but the little tiny person here is not this person. They're actually in the middle. So already we're not as worried about this weight-based dosing. And then if you look at the weight-based curve, very similar, maybe a little bit tighter. The individual level data at the 120 minute and the 90 minute don't differ. So if you do a paired t-test, they're not different. So maybe I was just being over anxious and neurotic, but it needed to be done. So I don't think we need to do weight-based dosing. Here's the actual clinical data. So bear in mind that this, as comparison to the other one, is now effectively open label. So the fact that we're getting much higher response and remission rates should be taken with that grain of salt. But we are hitting an 85% response rate and a 75% remission rate that's sustained at 4 weeks, which is, I can't think of a sliding window of 12 patients that I've ever treated where I've seen that. So it can happen by chance. This could just all be expectation bias, but I think that's pretty remarkable. And then we actually looked at the serum levels and the outcomes. And so here is their change in MADRS score. So as a proportion, higher is better. That's a greater decrease. And you have their serum D-cycloserine concentration at 90 minutes. So it's already predicting. So kind of consistent with that first study where if they took it as indicated and was more than 60 minutes, they were more likely to get better. And then at 90 minutes, and then at 120 minutes. And so for reasons I cannot explain, there were 3 individuals that were not absorbing cycloserine, and they were not it wasn't a weight function, wasn't anything like that. These people were not absorbing cycloserine, and they did not get better. These are the 3 people that did not remit. The ones that got higher concentrations, so above 6 microgram per milliliter, they all achieved remission over the 6 weeks. 4 weeks. Another way of looking at this is just showing as a direct t-test. So you can see that pretty clearly. There's a weak effect at 60 minutes, stronger and stronger. So stimulating at the 90 to 120 minute would be associated with better response if they're getting to the right level. Now, this was, there are little stars over these, but I'm going to give you context. They did accumulate over the week, but we're talking about an increase of on average 2 microgram per milliliter over a week, and on average 1.2 microgram per milliliter over the weekend. So if you extend this to a 6-week treatment, they will not exceed the 25 microgram per milliliter presumed threshold from where it goes from agonist to antagonist. So this is not clinically relevant. This is statistically there, but not clinically relevant. Okay, so what do we think? I'm satisfied. I think it's safe. And I'm satisfied that it's enhancement because I've never seen 75% remission. I'll be proven wrong by the large study, I'm sure, but this is exciting and promising data. Okay, so again, there's SAINT protocol that's come about, really has upended the field, and people now believe that you have to deliver multiple treatments per day. And it does kind of build on this idea of metaplasticity, excuse me. Where there have been a lot of attempts at this where the treatments were too close together. So if you give it anywhere between 15 minutes to 40 minutes, there is no benefit over giving a single treatment. And they've done a number of different trials proving that. If you lengthen out the length between the treatments to an hour or 50 to 120 minutes is what the data would suggest, then you may actually get these compounding effects where each stim leads to an additive increase in MEP at the very least, and potentially clinical effects. So we wanted to test this because what if cycloserine did that? Or what if it occluded it? That would be the worst thing. So again, we went back to the motor cortex. And so remember what you're doing is you're stimulating the part of the motor cortex that represents small muscle in the hand. So the FDI, it's really small and localized. You can get it very cleanly. And if you use neuronavigation in the person's MRI, you can actually reliably elicit MEPs from the same place. And we did serial measurements, so at the same intensity over time after 2 different theta bursts. And we did these input-output curves to see whether or not you're actually changing the ensemble representation in the muscle. And so this is published. So again, I'll gloss over it, not gloss over it, but what you can see is that the data wasn't simple. Data is never simple. So the statistical model here would show that D-cycloserine is leading to an overall improvement in plasticity. And it does kind of come out. You can see here, it's all normalized to baseline. And here we're renormalizing out before each theta burst. So again, theta burst, an hour, theta burst. So what you can see is that for a single administration, a single stim, theta burst doesn't do a whole lot in healthy individuals. I forgot to say, these are healthy individuals. If you add D-cycloserine, you actually can show an enhancement. But when you come back an hour later, there's been some metaplastic effect that is now allowing the placebo condition to catch up. And you can kind of see that better here where it's all normalized to baseline, where there really doesn't seem to be any superiority as you go out. So why does that matter? These 2 different measures of plasticity capture different processes, and we don't know which of them is important for treatment outcomes. Our previous one, the only one we were able to rescue when I laid out the case for you at the outset, was the stimulus response curve. We were able to rescue that. We did not rescue this with cycloserine. And so I was very interested to see what would happen with the stimulus response curves. And so here again, theta burst, 1 hour theta burst. Here's all normalized, renormalized to before receiving each respective stim. And here it's all normalized to baseline. And what you can see is that the cycloserine condition led to a robust increase in the slope of this input-output curve, suggesting that you have had a marked change in the kind of the penumbra, if you will, of the representation of the FDI. So what do we think about multiple daily interventions? This is getting progressively fader and fader. but I'm still not convinced here. I think we'd have to do the clinical study, and we actually are, despite the woo-ness of the implicit association test. I feel, and that the effects that we saw in suicidal ideation, that the population that needs this the most are individuals who are acute risk for suicide, who are acutely suicidal. And so we just launched a trial 2 weeks ago in previous suicide attempters who are acutely suicidal, doing twice a day randomized to either placebo or D-cycloserine to see whether or not we can actually get an effect on suicidal ideation and keep them well. And those people were following out for 6 months to see whether or not it impacts their hospital presentations and future suicide attempts. Because again, that meta-analysis I showed you said that we could use that test to predict suicide attempts within 6 months. So we'll see whether or not that actually pans out. So in summary, I hope I've given you a compelling case that cycloserine as a prototype or as a first comer has unique effects on TMS-induced physiology and can be used to improve outcomes, at least in depression. I think these intersectional approaches, trying to target LTP-LTD mechanisms, again, coming back to fundamentals that TMS is a tool, it's not a some kind of mystical thing, that we can start to think about this as a circuit level treatment, and we can start to bring in different adjuncts in order to make outcomes better. And I'm really excited because this is a relatively unexplored space. And I do believe that we're going to see a lot of new activity in this space, and we will make a lot of mistakes, but we will eventually get it right. And we'll hopefully, take this tool and this treatment from being something that is a flip of the coin, 50% chance you'll get better, to hopefully we'll replicate that 75% remission in the long term. And with that, these are the people that actually did the work. And I'd be happy to take any questions.
That was great. Thank you. But you talk really fast and I don't know if I absorbed it all.
Sorry.
So I just need clarification around the issues of your follow-up for the outcomes. Are you you mentioned suicide at 6 months and impact on hospitalization. Are you following functional outcomes out past the 6 weeks?
Past the 6 weeks.
Well, you had 4, then you had 6 weeks. So how far out are you going to follow?
These suicide kids? Or in general?
So in general, I mean, the whole presentation of the severity of their depression as well as their suicidal.
Yeah. So once I can get CMC, clinical trial material manufactured, we have funding to do a fully powered study with 263 individuals with depression. And those people we are going to follow 6 months out and get functional measurements going out that far. The data that we have to date, again, was really funded on a shoestring budget, and we just didn't. But the suicide data, we are following them out 6 months, and we have permission to access health records. So all of the records in my province are centralized, and so we can get access to whether there have been changes to medications, whether they've had to start new medications over those next 6 months, if there have been any emergency department visits, hospitalizations, and we are contacting them to repeat the Columbia Suicide Severity Rating Scale. So we're trying to be as rigorous as we can be on all of these kind of long-term outcomes. And what I glossed over again is that the funder wants us to look at emerging adults. So these are 18 to 24-year-olds. The idea being that early intervention can have the maximal impact. They're all 18 to 24-year-olds with a prior history of suicide attempt, because they survived, and current suicidal ideation. Yeah.
My one? All right. Thank you very much, Alex. That was wonderful. Great stuff. I guess my question is in regards, could D-cycloserine enhancement be related to something else? So, and I guess there's 2 parts to that. Is there any literature out there that if you are on an antidepressant or ECT and get D-cycloserine, do you improve? And then I guess in the folks you studied, were they on antidepressants, and was there any difference in response based on what they were on, whether they were on it?
Yeah, I'll go in reverse order if that's okay, because it's easier. So they were predominantly on agents, and most were on multiple agents. So these were your prototypical TRD population. There was one individual on no drugs because she had never tolerated medications, and so because that was one of our criteria, either have failed or not tolerated. But yes, no, these were quite ill people, and they were all on drugs. What's fascinating is this is anecdotal, and I can't actually say this beyond anecdotal, but we are starting to see the ones who went into remission are starting to show up again seeking TMS now 4 years later. So they stayed well for a long time, which is atypical for TMS. And most of them got so well that they stopped their medications after a couple of months. And these would have been people with multiple prior episodes with a 90% risk of recurrence, right? So that's anecdotal, but interesting. So what do we know about like D-cycloserine and ECT? I'm pretty sure there was one study that was abandoned pretty quickly because it didn't show anything. But they were using a 250 milligram dose, as I recall. Cycloserine has been studied as a standalone antidepressant, but not at this dose range. So it's been studied at 1,000 milligram dosing, where it's really trying to act almost in a ketamine-like fashion as an NMDA receptor antagonist. And the first study had a weak efficacy signal. The second had like an effect size of 0.3, but high rates of adverse events, hyperacusis, you know, all the things that you would expect from an NMDA receptor antagonism. And I'm really sorry, I forgot the first question already.
Augmentation with antidepressant.
Oh, so sorry, to that, there's I forget his first name right now, Chen out of Hong Kong, who did a study using it to try and prolong the effects of ketamine. And so what they did was they did intravenous ketamine and then put them on, again, 1,000 milligrams a day for, I forget how long. It was a period of 8 weeks, I think. It didn't work, but it did have a specific effect on suicide. So those that were continued with cycloserine had decreased suicidal recurrence over the period of the trial.
So I apologize if this is kind of outside of what you're going over. I'm just wondering what the relationship and what your research has leaned on with D-cycloserine and PTSD, and did that kind of proliferation inform the use of D-cycloserine in depression, or was it vice versa? And what maybe you've learned from that PTSD literature that's helping you inform and kind of move into this space?
Yeah, so when I'm at ACNP or at other meetings, I give Kerry Ressler the shout out for having accepted me with this idea, because this is something I've been wanting to do since 2005 when he gave his presentation at the Society for Biological Psychiatry. He gave a plenary where he was talking about combining D-cycloserine. At that time was a specific phobia exposure therapy, and his PTSD stuff was just beginning. And my reaction at the time was, that's great, but that's the wrong way to use this. You should try and do this with a brain stim or a targeted controlled stimulation protocol so that this will actually work. But to your actual question, what do I learned from the failures? And it's not, I mean, it's not just failed it's failed all over the place. This drug has been trialed all over the place. It's been trialed in schizophrenia to try and target negative symptoms. It's been trialed in OCD to enhance ERP. It's been trialed in a lot of different ways. And so what I take from the failures in other areas is that they have, well, Kerry's study, I think he overdosed in the first one and underdosed in the second. Because he went to 500 milligrams in the first, and then he went to 50 in the second big one that failed. So I think if you were to look at our PK data that we now have, that wouldn't really be expected to work. Well, I don't know if you can say that, but I think he overdosed, then underdosed. And then I think the other part of the whole equation is that these were all, for the most part, done with a psychotherapeutic intervention, which is effort dependent. And so the nice thing about STIM is that it's effort independent, and they're getting a targeted treatment that, you know, there's a version of PTSD exposure therapy where somebody engages and then aborts, and you're actually reinforcing the process or the ERP process, right? Now, add to that the fact that they're only doing it once a week for most of these trials were 12 weeks in length. I just don't think that's sufficient in order to have a separation effect. So I think it was always a risk of doing daily dosing. And we knew that risk, and we had to test it, and we tested it in the best way we could, trying to see whether it was going to occlude. But I do think it is this compounding effect, and then the fact that it is daily dosing in combination with a controlled stimulus. I gave a long-winded answer. I hope I actually answered your question.
Hi there. I have a quick question about your future protocol that you want to do for the clinical trial for depression.
Mhm.
Is the plan to do just a 2-week course of the cycloserine with TMS and then nothing else and track their depression scores over 6 months?
So the plan is for this one to actually, the reason we've been doing shorter trials is because we're worried about a floor effect. But with 263 people, that won't matter. So we'll have enough statistical power for a small effect. So what we are doing is we're actually going to combine it with the FDA 6-week approval. So it's going to be combined with a 6-week course of daily TMS, and the drug will be given, drug or placebo will be given for 6 weeks. And then they're out in the wilderness, we see what happens.
Just a question that relates to kind of the so-called specialness of this, because some pubs are coming out on like using ketamine with repetitive TMS to increase plasticity. And I'm like a trained neuroscientist, and I'm just getting into TMS research. So I mean, I've had the same thought of, sick patients and how we can boost. So what are your thoughts on this, like relative to ketamine, and is it really just the good safety profile of D-cycloserine that puts it above?
Like where would this fit into an algorithm? Is that what you're asking, or?
Just
Or would I
like
choose to
kind of
give
like in
someone-
context of where D-cycloserine is with promoting plasticity versus like other agents we might consider like ketamine to combine with TMS?
Oh, I see what you're asking. So I don't consider cycloserine to be a special drug. It was just the one where there was sufficient data to say that this is worth pursuing. And because of its regulatory advantages, we could get it going faster. I don't think it is the best version of it. I think it's very slowly absorbed. You can imagine that if you could engineer a prodrug version of it or a moiety on it so it's faster absorbed so you don't have to take it 2 hours before your treatment, which sick people can't do, there'd be a lot of reasons why this can be improved upon. Where if you were to use something like a ketamine in combination with TMS, I've admittedly, maybe I just don't understand it because sometimes that happens. I don't understand how combining an infusion of ketamine with TMS simultaneously is actually advantageous and not more likely to do the opposite. Because if you're trying to drive plasticity while simultaneously leading to non-specific global trophic factor expression and synaptogenesis everywhere, you're actually going to destabilize the circuit that you're trying to drive. So to me, it doesn't make sense, but I don't think we really understand how ketamine works yet. And again, I think, you can think of all kinds of different drugs that do all kinds of different things on synaptic plasticity that we could actually use to think about where these proteins are expressed in the brain to try and use TMS as a backdoor. And so one of the things that we're really interested in doing, and we have a study about to launch, is actually using phosphodiesterase inhibitors because you can actually target their specific expression elsewhere in the brain. So it's not going to be this non-specific thing that's expressed everywhere. You can actually use TMS as a backdoor for PTSD, for example. So I do think this is just the tip of the iceberg, and we're going to start to get a lot of really interesting data come out on this. That's as non-committal an answer as you're going to get from me.
Alex, thank you so much for your awesome talk.
Thank you all. Thank you.
We see in the clinic that depending on the when we use the neuropsychiatric medications, depending on the dose, depending on how often you use, they have tremendously different interactions with receptors and response. And I think that what you are doing with D-cycloserine, which is dissect to see exactly dose, to see exactly what's the timing, it's very thoughtful, and I'm sure that there will come a lot of follow-up studies on your work.
Yeah, please, somebody replicate my data. This has to be independently replicated or no one's going to buy it. Thank you.